Good morning, everyone. Welcome to day 18 of Acharya Rad Connect 2025, a premium online webinar series organized by the Department of Medical Imaging Technology of Acharya Institute of Allied Health Science in association with Indian College of Radiological Technology. I, Arjun, will be your host for today. Thank you for all of you guys for joining us. Before we dive into the session, let me take the pleasure of introducing our esteemed speaker for today. It's my honor to introduce Mr. M. Devaraj, a senior MRI technologist, RSO, and assistant professor in Sri Ramakrishna College, Coimbatore, Tamil Nadu. With over 35 years of clinical experience as a senior technologist, Sir has truly seen an evolution of the MRI technology. In addition to his extensive clinical expertise, Mr. Devaraj brings with him more than 7 years of teaching experience, where he has been shaping the future of healthcare professionals. Sir has attended over 50 international and national conferences and published several research papers in reputed journals. His wealth of knowledge makes him a highly regarded expert in this field. We are truly fortunate to have him here today to share his expertise with us. Please join me in welcoming Mr. M. Devaraj. Over to you, sir.
Good morning, everyone. I would like to thank this organizing committee, the Department of Medical Imaging Technology, Acharya Institute of Allied Health Science, and Indian College of Radiological Technology. And especially thanks to Mr. Jiva, lecturer, Department of Medical Imaging Technology, and then Mr. Manas Kumar, lecturer of Medical Imaging Technology in AIHS, Mr. Swapnil Shetty, and Ms. Muril J. Gomes. Thank you for inviting online lecture. So today my topic is MRCP. So my content is introduction, definition of MRCP, the anatomy of liver biliary tree and indications, contraindications for MRCP, patient preparation, protocol and applications for MRCP, and conclusions. So MRCP is a special type of non-invasive radiological examination that produces detailed pancreatic images of hepatobiliary and pancreatic system, including the liver, gallbladder, bile ducts, and pancreas and pancreatic duct. What is MRCP? MRCP is magnetic resonance cholangiopancreatography. The cholangio means bile duct and pancreato means like pancreatic duct. We are going to help of that MRI machine. So we will learn that study about the bile ducts and pancreatic duct. MRCP is used to diagnose and evaluate various conditions related to the liver, bile duct, pancreatic, such as bile duct obstruction, gallstone, pancreatitis, and pancreatic cancers, liver tumor, and biliary tract disease. So biliary system, also known as biliary tract, it is network of organs, ducts, and structures responsibility for producing and storing and transporting the bile from the liver to duodenum. The main components of biliary system is, liver produce a bile fluid that helps to break down the fats and absorbs fat-soluble vitamins, and bile ducts, bile transport from the liver and gallbladder to the small intestine. The right and left hepatic duct carry bile from the liver. Common hepatic duct join the right and left hepatic ducts, and cystic duct connect the gallbladder into the common bile duct. Gallbladder stores the bile from the liver on concentrating and releasing if needed. So common bile duct carries bile from the liver to the small intestine. The ampulla of water, this is one. The point where common bile duct and pancreatic duct connected before the bile emptying into the small intestine. Now move on to liver, little bit liver anatomy. A liver is a large meaty organ that sits right side of the abdomen. The large gland weight around 1,500 grams. Liver consists of both exocrine gland and endocrine gland. The liver has two large sections called right and left lobes and also consists of 8 segments. The first segment is caudate, that right lobe contains 4 segments and left lobe contains 3 segments. So gallbladder is a small pear-like shaped organ that lies on the cystic plate. It is called it as gallbladder bed. So under the liver, it is located at a segment of 4B and 5. This is the gallbladder is sitting on the 4B and 5. The primary functions as a storage of bile. The size of the gallbladder is around a length 7.5 to 12 centimeter, width 2.5 centimeter, wall thickness less than 3 centimeter. The volume of the gallbladder is normal in normal condition 30 to 40 ml, can expand up to 60 ml. In case of any obstruction, it's go up to 300 ml. The traveling path of bile. So bile is produced in the liver and flows into the tiny channels, and bile flow from the tiny channels into the hepatic duct, which collected from the multiple lobes of liver. The right and left hepatic duct merge form the common hepatic duct. The common hepatic duct is connected to the gallbladder, where bile is stored and concentrated. Then it's like a cystic duct. When the food enters into the small intestine, the gallbladders contract and release bile into the cystic duct. You can see here that bile is releasing here. Then the cystic duct is merged with the common bile duct, which carries bile into the small intestine. The ampulla of water. This is the ampulla of water. The common bile duct empties into the ampulla of water, a muscle wall that regulates the bile flow. Then small intestine, the bile enters into the small intestine where it aids in fat and digestion and absorption happen there. So we go for gallbladder anatomy and functions. The gallbladder's main function is it store and concentrated the bile, a yellowish green fluid. You can see the gallbladder. This gallbladder fundus, this bile, this gallbladder body. This one is that gallbladder neck, and this is cystic duct, right hepatic duct and left hepatic duct. This is a common hepatic duct. So this is common bile duct. So go to the duodenum. It helps to break down the fat into the small intestine. When eat a meal, especially a fatty one, the gallbladder is contract and release the bile into the common hepatic duct through this a common bile duct through the series of ducts. This is the functions of gallbladder. Now we can see this a basic principles of basic principles of MRCP imaging is, here you can see the 3 images there. This is T2 weighted imaging. This is heavily T2 weighted imaging. What is the difference between that T2 weighted imaging and the heavily T2 weighted imaging is? So here we can see the image in background structures like liver, stomach, and duodenum, and this common hepatic bile duct, and this gallbladder. But you can see here that is heavily T2 weighted imaging. It will show only that the fluid content area, because of we are going to increase the TE value. What is T2? What is T1? So T1 is short TE and short TR. T2 is long TR and long TE. But the image based on the TE is based on T2 weighted images, but TR based on T1 weighted images. So the principles of MRCP is the technique provide invasive evaluation of bile tree that the background of these this image is totally suppressed because of we are increased the TE values like a 600 to 1000 milliseconds. What happened is these particular it will increase the enhance the fluid that fluid level the fluid, so the background structures are suppressed, will get only the that fluid content that organs. That is the important of that MRCP sequences. So for example, you can see that this one, these TE values like around 7000 milliseconds. So background structures are suppressed, but you can see the TE value is 80 milliseconds. You can see the image, we can see the other organs also. But our this technique is MRCP only. So you want to see the biliary system and pancreatic system. So we suppress background structures and we want to see the only that background. This is like a fluid area of that biliary systems. You can see this like we applied 700 milliseconds, but it will appear fluid only. So you can see the stomach fluid and this is a gallbladder and duodenum and the kidney cyst. So everything appears very bright in this image, but we can see the next 80 milliseconds, we can see the background structures but fluid is like a little bit suppressed. This is the technique for MRCP. Those clinical indications for MRCP is that uses of that clinical MRCP. So this elevated, we can find this disease in MRCP like jaundice, elevated liver enzymes, and pancreatic disorders, acute and chronic pancreatitis, and pancreatic cancers, suspended tumor, pancreatic ductal anatomy, and gallbladder disease, gallstones or suspected gallstones cancer, and gallbladder inflammation or dysfunctions. A linear disease and post-operative evolution, abdominal pain and discomfort, the screening and surveillance, and very useful for pre-operative planning for evaluation of biliary tree anatomy and this after this surgery. So contraindications is most important for technologists. So patients with any metallic implant, we should not enter the patient into the zone 4, that is like a gantry. So what are the contraindications? That cardiac pacemaker, aneurysm clip, neurostimulator, insulin pumps, and magnetic foreign bodies like bullet fragments, surgical plates, and claustrophobia patients also. The obesity patients also is a contraindication for MRCP. The pregnancy, breastfeeding women, and allergies to contrast media, these are all contraindications for MRI. So relative contraindications, tattoos or permanent makeup may cause skin irritation or burning. Dental implants or bridges may cause artifacts or discomfort. Hearing aids or cochlear implants may be affected by MRI scanner noise. The insulin pumps or other medical device may be affected by MRI scanner and a magnetic field. So patients with any metallic implant should not enter inside the magnetic bore. This, for example, patients with a small like that metal, it will cause susceptibility artifacts in that image. This is not a good image. It's a artifacts in that image. We cannot report this like this kind of patients. We should not do MRCP. So this preparation, patient preparation, most important in that MRI. So very, very important for this, like you have to clearly this manipulate like patients that investigation, you have to investigate the patients very clear before doing the MR scans. So that patient should be fast 4 to 6 hours before the exam. So nothing to eat or drink, And we need a satisfactory written consent form must be taken from the patient before entering the scanner room. Ask the patient to remove all metal objects, including keys, coins, wallets, and any cords with magnetic strips, jewelry, and hearing aids and hairpins. Ask the patient to undress and change into hospital gown. Claustrophobic patient may be accompanied with one attender or the inpatient, we can allow the staff nurse. If needed, provide sedation or recommended for open MRI. So always provide buzzer to the patients, very, very important. Explain the whole procedure and benefits and risk to the patient and answer the questions. Note down the weight of the patient and instruct the patient to hold their breath for the breath hold scans and breathe gently for gated scans and review the medical history so to identify the potential. It's very, very important. So it depends on that medical history. We are going for that we are select the protocols. Inform the patients about use contrast agent and any allergies. Taking sometimes explain to the essential of upcoming MRI examination process allowed to save the many minutes during the examination and decrease the rate of failures. Always so motivate the patient before doing that MRI scans. So checklist is most important for technologist. Checklist is very important. So what is MRI? MRI is magnetic resonance imaging. But here, so always technologists and budding radiographers or students, you think about this like a metal result in injury, because any metals inside the magnetic field, it will cause that injury to the machine or patient or attender. So carefully you have to check this list. In case of that any metal is there, you should not allow the patient inside the magnetic board. So before doing that MRI, you can check all these things like a hairpin, a pin, wigs, clothing that including metals, watches, and activity trackers or rings, dentures, jewelry, glasses, face makes, face eyeglasses, and hearing aids, artificial limbs, and diabetic monitoring devices, RF ankle bracelets, silver packed wound dressing, and medicine patches, and inpatient's ID bracelets, microblade eyebrows. So this anything is there, you should not enter the patient should not allow to enter the magnetic bore. That means zone 4. So always before doing that MRI, and this technologist, this is an important role. You have to check this list, this one, and you document it. Then only you allow the patient inside the magnetic board. This is the checklist. So in case of patients usually we are introducing that buscopan to the patients or that abdominal patient because of that the bowel movement is there now. So we are introducing the buscopan. Before introducing the buscopan, you have to ask 3 questions. One is glaucoma or any asthma patient or cardiac patient. If anything is there, you should not give buscopan to the patient. This is most important. Otherwise, you document it and you can go for scans. The positioning is very, very important. The position the patient in supine with head first or feet first, and position the patient over the spine coil, that means table, and place the body coil over the upper abdomen from nipple down to iliac crest. Securely tighten to the body coil using straps to prevent the respiratory arteries. Give pillow under the head and cushions under the leg for extra comfort. Landmark below the xiphoid process of sternum. The respiratory pillows are placed on the patient. Check for the respiratory waveform on the computer console. So this is 1.5 test law, say in our department. So before going inside the magnetic board, we have to check IV line to give for to introduce the buscopan. So before going inside, the saline is flushing, the checking for the IV lines, and then patient inside the magnetic bore, supine position at first, supine position. So this is one that what is that? That is the pillows. That is that a respiratory pillow that is placed on the abdomen and chest wall. This is most important. It will very useful for our scanning. Then after that, you have to place the coil in proper manner and then explain about the so like a procedure, and then you give the like give uh, this buzzer to the patient, and then you go for scans. This is 3 Tesla machine. You can see here, this is we are doing with the head leg first supine position here. We are placing the coil here, that it is the pillows, the respiratory pillows, placing in the chest across the chest and abdomen. And then place the coil and connect the coil in proper, and you give headphones to the patient for this communication with the technologist and the patients, which is very, very important to give instruction to the patient. Breathing instructions very important for this one. Then next one is this always you have to give practice in that table, breathing practice, and then after that you check the wavelength in that monitor. Then you go for scans. This is the positioning for MRCP. So why breath hold sequences is necessary for doing MRI scans? So you can see here that 2 images are there. One is um, proper breath hold sequence, that one. Another one is improper breath hold, that images. So you can see the difference between these two. This is a very good image, but it's a blurring. So artifact is there. So always the breath hold is very, very important. So before doing that, this MRI scan, during MRI scans. So before doing that MRI, this this one, this breath hold sequences, you go for before that zone 3, you have to give practice to the patient so many times. This is very useful for the upcoming protocols. So how to place the respiratory trigger navigator? So this most important for trigger imaging. This is a navigation box. To place the respiratory navigation box correctly in the middle of the diaphragm and off of the box over the right lobe of the liver, segment 8, and other off of the off over the lung. This is the correct placement of navigations. So you check with the other 2 planes. This is a navigator placing here. You can see that liver and this off of the navigation in the lung, and another off of that navigation box in the liver. This is the correct position. I'm going to show that one. So this is the correct setting of the navigation box. This is not correct setting because that navigation box is too high, and here that navigation box is too very low. So this is not correct position. This is these navigation box is important for the image quality. What is like a respiratory trigger? Aim of the respiratory trigger is to respiratory the pillows placed in the across the abdomen and chest wall where the great respiratory exclusion occurs. That place you have to place the respiratory pillows. It is very, very most important. Some sequences depend on the respiratory movements. So the aim of the respiratory trigger is to biliary treat with improve the spatial resolution and reducing the artifacts caused by the respiratory motion. So can be used in patients who are unable to suspend respiration. We go for a respiratory trigger method. The next one is how to do a respiratory wave form. You can see the respiratory form waveform here. So I'm going to show how to do in MRI department. So this is Tamil. So you go for your language. You can see the waveform here. The patient is breathe very nicely. So after that, you can see the image quality here. So this is a respiratory breath hold method. This is the breath hold method. I'm going to show once again. So this you can see here now. Once give the instruction, you can see the waveform. The patient is hold their breath is very nicely. After 15 seconds, we will get that images. Okay, you can see the image. This is the breath hold method. The another one is respiratory triggered method. So the respiratory trigger method is already explained that the box is placed in the diaphragm. The patient here they see the patient is maintaining a constant respiratory rhythm. So then we can get the good image quality. So you can see here that image quality of once again. This is the respiratory trigger method. You can see the image quality. So that what is the difference between that without and with respiratory trigger? You can see the image here over here. This is without this respiration trigger. This is a respiratory with the respiratory trigger. You can see the image quality here. So that another example. This without respiratory trigger. This one is respiratory trigger. You can see the image is very well in this particular this image. Next one is breath hold, free breath hold in this one. So a lot of artifacts there. This is respiratory gated technique. You get good image quality here. So why fasting is needed for MRCP? So in MRCP, the very important is minimum 4 to 6 hours. The fasting is very, very important because to reduce the fluid secretion within the stomach and duodenum. At the same time, increase the fluid density in the pancreatic duct and pancreatic duct and biles also. They reduce the bowel peristalsis and promote the gallbladder distension in that image qualities. So what happened is you can see that here, this is improper that preparation. You can see the fluid in the stomach and duodenum. So this particular, that's a duodenum, this fluid, they overlapping the image quality. But this NPO sequence, you can see here that appears that images appears very well. So always that 4 to 6 hours NPO is very, very important for that MRCP sequences. That 1.5 Tesla, we go for 1.5 Tesla and 3 Tesla also. But 3 Tesla, it gives twice that SNR. And strong magnetic field may be given a high spatial resolution. It will give that good image quality in especially in pancreatic ducts. This is the protocol for MRCP. 3-plane localizer, axial T2 haste and coronal T2 haste, axial diffusion sequences, diffusion weighted imaging, and next is tech slab haste, another axial T1 phase and in phase out phase. And that is what is haste. Haste is the Fourier acquisition single shot turbo spin echo sequence. Then next one is 3D sequences. These are most important for MRCP. We can go for we can do in that coronal and axial section. So this is the scanner time MRCP protocol. This is Scout and T2 weighted imaging and 3D T2 space and fast spin echo sequence, and then is in phase out phase sequence, the T1 pre-Godot and real time dynamic images and T1 post Gado, delay 1, delay 2, and delay 3. So totally, we have to finish within 30 minutes. This is a sequence for protocol for MRCP. How to do these MRCP sequences? First, we have to run 3-plane localizer, axial, coronal, and sagittal, and plan the axial section in the coronal images. So always we take the axial and sagittal, axial and coronal and sagittal, plan the axial section in the coronal plane, pushing the block across the liver, and slice must be sufficient to cover entire biliary tree from the diaphragm to the C-lobe of duodenum. Check other two planes, and sagittal and coronal. So before that, you have to instruct the patient to hold their breath. So during the image acquisitions, then after that, you will get this image quality in axials. Now let's go for this coronal as axial sections. The coronal section, plan the coronal slices in the axial images. The position block is across the liver, and check the other two planes, and slice must be cover the whole liver from the anterior wall to the posterior wall in sagittal plane or axial plane. Face direction must be right to left, avoid the artifacts from the heart, and instruct the patient to hold their breath during the image acquisition. This acquisition, then we will get that good image quality here. This is a coronal image. So heavily tutti weighted images. This is the most important sequence for that MRI. So this is a 3D images, the slab. It will, this nearly more than 100 slices. The plan, how to plan these 3D sequences. So take 3-plane, that sagittal, coronal, and axial. Plan the 3D axial based images in position block in the across the common bile duct and pancreatic duct. Slices must be cover the whole the common bile duct and this pancreatic and gallbladder. That phase oversampling must be used to avoid the wraparound sequences. So then go for that. You have to run the sequence. This is actually triggers patients. It will take more than 4 minutes or depends on that slices. Then we will get that 3D images. So 3D images. This is axials, that 3D images. Axial sections is planned in the coronal image. The position block across the that bile ducts, and slices must be covered the whole common bile duct and pancreatic duct and gallbladder. And that phase of our sampling must be the avoid that wraparound artifacts. Then we will get that 3D images. So this is the base image of that 3D sequence. You can see the image. So these are 3D images. It will shows only that water content area. That means that fluid, the enhanced area. This is the purpose of MRCP sequence. This MRCP sequence, once again, you can see the fluid gallbladder and the radicals, and right hepatic, the left hepatic, the common bile duct. So this is the MRCP sequence. Okay. So this after that you go to that MIP and post processing. Then you will get this 3D images here. You send the base image to the PACS to the doctor for reporting, and also do a 3D MIP images and send to proper manner. The another one is that is thick slab. So patient is not able to hold that breath in for getting scan. So you go for breath hold sequence. It will take 7 minutes only. So how to plan? This thick slab, nearly 40 to 60 mm on the so like a axial image. So that coronal oblique, you have to cover gallbladder and pancreatic duct. The position block across the common bile duct, and so rotate anti-clockwise. The clockwise, 20 to 30 degree anti-clockwise include the common bile duct and the pancreatic duct. The slices must be covered whole that bile duct and pancreatic duct. Instruct the patient hold that breath during the image occasions. So then, it's a single shot image, you will get the 3D images. This is like a 2D image, thick slab. The another one is this anti, so like that anti-clockwise. This is clockwise, this is anti-clockwise. Plan the coronary images, left anterior oblique, the thick slab on the axial haste image. Position the block across the common bile duct and rotate the block 20 to 30 degrees clockwise to include the common bile duct and gallbladder. Slices must be sufficient to cover the whole common bile duct and pancreatic duct, and instruct the patient hold their breath during the image acquisition. Then we will get this lines. We can do a multiple angulation. We can do multiple angulations in your department, depends on that requirement. So 3D, another one is in case of patients with any like lesions in liver or that cholangiocarcinoma, you go for dynamic studies. So after the contrast injection, so go for that arterial and portal and rate portal and the equilibrium. Arterial scan is 25 seconds after the injections, and portal phase is after injection of 60 seconds, and last portal is this late portal is 100 seconds, and equilibrium phase means that means like a delayed scan for 180 seconds. Then 10 minutes delay depend on this the image that disease process. You go for delayed scans. Then send to the images to the fax in proper manner. So this is like 3D that dynamic studies, the how to do the dynamic study in department. So breathing. This is totally the breath hold sequence. It's very, very important for breath hold. So we need a cooperation from the patients, then only we will get this good image. This is most important for the radiologist. So these images is very, very important for radios for reporting. So this is the first phase after the contrast injection with the help of that pressure injector. So you can see the image here over here. So nice image here. The patient is holding that breath is very nicely. You can see here that this one.
மூச்சை விட்டுருங்க. மூச்சை உள்ள இழுங்க, அப்படியே நிறுத்திக்கங்க.
This is Tamil. You can go for your language.
மூச்சை விட்டுருங்க.
So like that you have to do in the department. This why this breath hold is very, very important is we are injecting the contrast. So we need facing images that portal arterial, so that most important for reporting for the doctors. Okay, so over. So then sometimes, so you can see the picture over here, that is the fluid in the that stomach and duodenum. It will overlapping the image quality. Sometimes you can give that pineapple juice. This that background fluids are suppressed. So that this is one of the technique. This is not standard practice. So we done in MRI department 4 days back. You can see the image. Doctors want to see that pancreatic duct and measurement also. So here there's a lot of background structures are there with the fluid content. Stomach fluid is there, and the duodenum also is contained with fluid. After this consuming of that oral negative oral contrast, that pineapple juice, you can see the image quality where that background that fluids are suppressed. This is the one of the technique. So that applications of MRCP is very, very useful for cholecystitis patient. That means the gallstone in the gallbladder. So this is the common bile duct. So gallbladder. This one is this cystic duct, then right hepatic duct, this left hepatic duct. So these stones here, the gallbladder, it is called it as cholecystitis. So that is we can this remedy is so remove the gallbladder. That is the you can see in that image in MRCP. So that's very, very useful for this cholecystitis patient for MRCP sequence. You can see a lot of stones in the gallbladder. The another one is cholecystitis. What is cholecystitis? Cholecystitis means obstruction in the obstruction in the duct, in cystic duct. So that you can see the lot of stones. So moving that they are obstructed in the cystic duct. So here, so remedy is remove the gallbladder. That also. So you can see here that in MRCP sequence, it shows that lot of stones is there, and at the same time, cystic duct is stone is that obstructed, and the gallbladder is distended. The next one is choledocholecystitis. That means that stone in the common bile duct. You can see here common bile duct. So this is very, very useful. You can see the MRCP sequence, how that is useful for MRCP. So you can see the common bile duct, lot of stones are there, obstructed. The common bile duct is dilated. So that the remedies go for ERCP method and remove the stones. So next one is cholangitis. Cholangitis means stones in the common bile duct, then infections also. So you can see the MRCP sequence is like stones are there and infections also are there. That is the remedies emergency MRCP can remove the doctors removed for that these stones become very clear. So that's a method of removing stones, ERCP. Next one is cholangiocarcinoma. It means that tumors in the that's it is called it as cholangiocarcinoma. This also is very useful in we can do in MRCP sequences. Next one is chronic pancreatitis. Is the pancreatic duct obstructed and dilated pancreas, and here you can see the pancreas is calculate with a dilated pancreatic duct. So this MRCP this sequence. And next one is pancreatic divisum. This anatomy. So anomalies in that pancreatic duct. These are two ducts are there. So this is very useful for this MRCP is very useful for detect the anomalies in the pancreatic duct. So then a liver protocol. In case of patients with any problem with that liver, go for a liver protocol. Always you have to add one 3D sequence, MRCP sequence. This is very, very important. And challenging for technologists, early to department. So you should wait for the patient. You should not patient should not wait for the doctors or a technologist. So it's very challenging for uncooperative patients. Very difficult to do in MRCP, and kindly handle the patients in emotional patients in the department. So who is the best technologist? Welcome the challenges and excellent with patients, and put time in setup for this like preparation, and do not complaints about examination length. So come to conclusion, proper patient preparation and questioning and appropriate protocols ensure a safe and successful abdominal exams, resulting in high quality images for accurate diagnosis and treatment planning. MRI technologists must be aware of the role of MRCP and MRI examination can play in overall medical management of patients today. It is critical that MRI technologists must understand and perform this examination to the highest possible standard. It helps to deliver high resolution images and high quality cutting edge treatment for patients and reduce the imaging time. So this is my reference. Thank you very much.
Thank you so much, sir. If anybody has any questions, please post it in the chat box so sir can answer it for you. So one student have asked the question, diffusion sequence role in MRCP.
Yes, that diffusion sequence is very important for, it's not for MRCP sequences. In case of any lesions in liver, or you go for diffusion weighted imaging. So most important, very good question.
Are there any questions?
Any other questions?
So a student have asked, which sequence helps to pathologize the liver like cyst, lesion, and carcinoma?
So always we have to do the T2 weighted imaging, and that heavily T2 weighted, that is T2 and T2 weighted images. That means double T2 weighted images very useful for like cyst. The cyst contains that fluid. It will appears in that an image in T2 weighted. It will like bright. You go for higher TE values like 180, 120. It will appears very bright. We can conclude cyst or any other pathology. So carcinoma, we go for normal sequences. That's enough. That carcinoma patient, we need a dynamic contrast study is very, very important.
Any more questions?
So any other questions? So my advisable is before doing for MI scan, here that the preparation and protocol selection is most important in MRCPs. So before doing that MRCP, you always you interact with the patients. You have to spend some more time to the patients and give instructions to the patients, and you give practice for that breathing techniques. This is most important in MR sequence. We are facing a lot of problems in after this doing for MRI. So that breathing techniques and is very, very important. Always you have to inform the patient before doing that MRI. You have to explain the whole procedure to the patient. This is my humble request.
So a student have asked a question, what is the role of haste in MRI?
Haste.
Yes.
What is the?
What is the role of haste in MRI?
This haste is was like Fourier that sequence. It will reduce the that we'll use for that breath hold techniques. It will reduce the time. So it will reduce the time. We will get that images very fast. That haste sequences. So instead of that T2 weighted spin echo sequences, it will take long time. We are facing a lot of that artifacts in that particular images. But haste sequences, that is single shot images, it will occur very fast. So only for these sequences, only for the that abdominal that images. So nice question.
If there are no more questions, I will wind up the session. Thank you so much, sir, for the detailed explanation of the technique involved in performing an MRCP.
Okay, thank you.
Your thorough breakdown not only clarified the procedure, but also deepened our understanding of its components. We truly appreciate your expertise and the time you have taken to share this valuable knowledge with us. Thank you so much, sir.
Thank you very much once again. Was like especially thanks to our participants and this organizing committee, so giving him an opportunity. Thank you once again.
Thank you, sir.
Thank you.
I just want to take a moment to sincerely thank everyone for your patience today. We know the session started a little later than expected due to some technical issues, and we truly appreciate your understanding as we work through them. Your time is valuable, and we hope that despite the delay, you found the session useful and engaging. Before we conclude, let me brief the participant about the next speaker for tomorrow. We shall have among us Miss D. Rajita, Assistant Professor of Department of Radiology and Imaging Technology and Department of Allied Health Science, Ramaya University, Bangalore, Karnataka, who will be taking on MRT2 relaxometry, clinical application and advancement. Once again, our sincere thanks to our distinguished speaker for sharing such valuable insight to us, and to all of the participants for your active engagement throughout the session. We look forward to having you join us again for another session soon.